Welcome to the Clinical Podcast Series brought to you by the American Academy of Optometry Foundation and the Primary Optometric Care Channel. Today's topic, assessment of low vision referrals before and after establishment of a low vision program at an academic medical center. Today's episode is hosted by Millie Brujic. The topical editor is Chelsea Bradley, and today's topical expert is Katie Niermann. Now on with the show.
Hi, I'm Dr. Mila Brujic, and I'd like to introduce you to Dr. Katie Niermann. Katie, tell us a little bit about yourself, where you practice, what your role is there.
Absolutely. I'm Dr. Niermann, and I currently work at the Illinois College of Optometry as an assistant professor. I work quite a bit teaching student clinicians in primary care and some low vision as well.
So, Katie, we're going to be talking about a pretty interesting topic today. We're going to be reviewing an article. It's called The Assessment of Low Vision Referrals Before and After Establishment of a Low Vision Program at an Academic Medical Center. Tell us a little bit about the article and really what they looked at here.
Absolutely. This article is quite important and intriguing to all of us that might be referring patients to low vision. So a major academic medical center looked at their electronic health records to figure out, are there more referrals after they established an in-house low vision clinic service? And it turns out there was way more referrals, but overall the referrals were extremely low if you looked at the numbers overall.
Yep, that was the interesting part. And I think clinically, there's always this question mark about when do you have the patient that's in your chair and when do you refer them for low vision services or provide low vision services in your practice, either one. But I think part of the clinical conundrum is that really changes the dynamic with you and that patient, because you're really kind of telling them now that your condition is more serious and it needs tertiary care. Clinically, what do you use, Katie, typically as the cutoffs for when you're thinking about referring patients?
Absolutely. That's a great question. So the patient sitting in your chair is typically someone that has irreversible vision loss. And we don't have a certain cutoff point in terms of visual acuity or visual field. And that's where it gets tricky. It's all about function. So if the patient is sitting in your chair and they're having trouble doing things that they love to do in their daily life, then they're ready for a referral.
Yeah, I think, Katie, one of the challenges, I really see this just talking to other colleagues, is we really don't think about it unless we have the geographic atrophy patient that's at 2200 or worse, when in actuality, the 2040, 2050 people are starting to really function a lot worse. Are there clinical cues or guidelines that you use to help yourself refer these patients? I know there's not a hard visual acuity marker. I know there's not a hard kind of functional component to it, but are there things that you're looking for and listening to with these patients to make sure they're getting to the appropriate care?
Absolutely. So typically, such as in this article, for example, they use standards where anyone that was 20/70 or worse in their better seeing eye, best corrected, they consider them as a resource for referrals for low vision in this particular article. That doesn't mean that someone that sees better than that is not good for a referral, but in this particular case, that's what they looked at. This particular article could not look at visual field because that's not in every single electronic health record, but visual field is also an important part as well.
And what do you think is the biggest limiting factor to clinicians referring these patients earlier? Is it, I don't know where the low vision site exists? Is it, I just don't think they're really ready for it? I mean, what do you think clinically on the ground floor is our limiting factor?
Absolutely. I mean, it's tricky because there's so many barriers out there. First of all, the clinician themselves may not know what their personal cutoff is to referring. Then on the patient perspective side, they might be in denial. If they go to low vision services, it means they have low vision. Also, in order to go to low vision, you have to have a clinic that's accessible. So the visibility of clinics is, in essence, an issue. In this article, they talked about a dramatic increase in referrals because they actually established a clinic in-house. So that seemed to help quite a bit.
It is interesting, though, and you're right. I agree with everything you're saying. The challenge was, Katie, I couldn't believe when I read the article, though, although like you said, and this is one of the first things you said, There was an uptick in the number of people that were referred, but it was still a relatively low number of those individuals that could potentially benefit from the services.
Absolutely. It was extremely low overall. In fact, about 90% of patients that are in that 2070 to 2200 range were never even referred at all in this particular study that could have been. So it's something that even though we've all learned about low vision rehabilitation services in our practice, it's always something we need to keep in our back pocket for our patients in daily practice.
Katie, being at the Illinois College of Optometry, I mean, you're working with students. Is there an increasing amount of awareness being brought up around low vision services in the students, in particular with the generation that they're now going to be taking care of when they graduate?
Absolutely. More and more, we are discussing with students that are about to practice what to look for in terms of visual function for referring patients. And in most optometry colleges and schools, we're so fortunate that we have in-house services, but that's not always the case when people go off and graduate and they're practicing in private practices or rural practices. They may not have in-house low vision clinics. So in those cases, they might need to think about it even harder to refer to outside sources.
Oh, Katie, thank you again. This was a really interesting article, and it was really interesting to see again how influential it can be to have those services close. Yet there's still that unmet need. I think that's the case with kind of all of these services. If we could get everybody to the services that were required, I think everybody would be functioning better. Katie, thank you for being on this episode of the American Optometric Foundation podcast.
Thank you so much for having me.